Welcome to the National Hemophilia Foundation's presentation, Ouch! Tackling Pain Together. I'm Dr. Michelle Whitcup and will be the moderator for this session. I will be joined today by Dr. Tyler Buckner, who is a hematologist and a researcher from the University of Colorado School of Medicine Hemophilia and Thrombosis Center. Also, Dr. Emily Wheat, who is a psychologist, also from the University of Colorado School of Medicine Hemophilia and Thrombosis Center. Mr. Sean Jeffrey is a community member who has severe hemophilia and experiences chronic pain. Will join us. These are our disclosures. So how can you get the most out of this session? First, please note where the chat box is on your screen. You can write your questions or comments in that area. The speakers will respond to you and to your questions in the chat box throughout the session. There is also a place in your screen where you can email follow-up questions to the speakers. Speakers will respond after the session is over. Throughout the session, there will be an interactive polling. You will see questions pop up for 45 seconds on your screen. Please participate so that we can learn from each other. Make sure to give additional feedback at the end of the session by filling out the evaluation. And remember that all of these sessions are recorded, so you can watch them online at any time. So here is our first pop-up question. On a scale of 1 to 10, how much pain do you have on a daily basis? You have about 30 seconds left. Again, on a scale from 1 to 10, how much pain do you have on a daily basis? Just a couple of more seconds. Almost done. Thank you for taking the time to let us know how you're feeling. So now we're going to go to the next question. You've done it before. You can do it again. It's going to be easier this time. Who manages your pain? Your primary care provider, your hemophilia treatment center, a pain specialist or clinic, infectious disease specialist, orthopedic provider, or somebody else. Or you don't need pain management. You've got about 20 seconds left, so please share with us as to who manages your pain. Just a few more seconds. And we're almost done. There you go. We're going to go into the next question. The third and final question is, are you satisfied with your pain management? Yes, no, or I don't need pain management. Are you satisfied? You've got 45 seconds to answer this. We're down to about 25 seconds. Are you satisfied? About 15 more seconds. If you receive pain management, are you satisfied with the care that you're receiving? All right, we're almost done. Good. Thank you for taking that time. So there will be more of those type of pop-up questions throughout the session, and we hope that you'll take the time to answer them. So now I would like to introduce you to the National Hemophilia Foundation's Medical and Scientific Advisory Committees, also known as MASAC, their Pain Initiative Subgroup. Started in 2015, we have multi-year initiatives with specific goals of addressing unmet needs within the pain community, specifically the lack of validated tools to evaluate pain outcomes. And we also want to develop areas of new knowledge, publications, and clinical guidelines. The group held an interactive consumer session at the 2016 Orlando Bleeding Disorder Conference. We discovered important issues to patients with bleeding disorders as well as their caregivers. And those were pain scales and pain evaluations that did not adequately address the multifaceted issues of pain, such as sleep, mental health, and the impact of pain on their life. They were also concerned as to how the national opioid crisis would affect them, as well as their ability to receive pain management adequately. You can see on the far side that what they considered to be their unmet needs, things like non-pharmacologic treatment options, their concerns about how opioids actually worked, as well as the misuse and abuse, and things such as research on cannabis to really understand its role in pain management and offer it as a treatment option. In response, the subcommittee developed a roadmap for reducing the burden of pain. And this roadmap included defining the gaps, increasing awareness, define and standardize measurements, and create treatment algorithms, followed by evaluating the impact. So what did we do so far under each of those areas? Under defining the gap, the subcommittee set out to send out a pain survey to the entire HTC provider community. We did that in early 2018 to assess what their needs were in pain assessment and management. We also did an extensive literature review in pain management and bleeding disorders. We wanted to increase our expertise within the community to drive improvement and change. So we added a board-certified pain specialist to the group. Of note, our group is very diverse. We have physicians, advanced practice providers, nurses, psychologists, social workers, physical therapists, pharmacists, and a statistician. To increase awareness, the group developed a detailed plan to address the needs expressed by the hemophilia community regarding pain assessment and management. And this is going to be described more in depth by Dr. Buckner as he discusses the Mesac recommendation number 260, Management of Chronic Pain in Persons with Bleeding Disorders. The group is in the process of developing provider pain management education programs for release this fall. There's also a manuscript near completion of the survey that we did in 2018 with anticipated publication in the Journal of Pain Medicine. So with that, I would like to introduce Mr. Sean Jeffrey and let him explain his experience of chronic pain.
How much pain do you have on a daily, weekly, or monthly basis? So me personally, I have a target left elbow and a target right ankle. So most of the pain I deal with is regarding those two issues. It's usually more arthritic style pain early in the mornings or in the late evenings, or if I haven't been that active. Other than that, though, most of the time my body's pretty decent overall and I don't deal with too much pain. But that's also coming from someone with a chronic bleeding disorder, so that is a relative opinion. Do I take any medications for pain? Yes, I do take some medications. I take an NSAID to deal with more of that chronic or arthritic pain that I talked about. But other than that, that's really the only thing I do. There are, obviously there are exercises and things like that. Yoga, stretching, trying to stay in shape, continually moving. If I haven't worked out or done anything active in a really long time, and then I try to do something, I'm way more stiff and stuff like that. Swimming is really helpful as well. There's some days where, I do an activity that I think is going to be beneficial, but then maybe I work myself too hard, and then the next day I might be paying for it with my joint pain and stuff like that. So when you do be active and work out, just make sure you're talking to your PT and choosing the right activity for you and not pushing yourself too hard. Question 2. Have I ever been asked to complete a patient agreement that discusses the goals and expectations of pain management? Personally, I have not done a patient agreement on paper or anything like that myself. I have had really good conversations with my providers and medical team, PTs, everybody included. So I have had those long discussions and very important discussions to have for not only my safety, dealing with how to resolve pain issues, and if, more medical needs are necessary, interventions are necessary for that, whether that's, pills or things like that. But I personally have not had a document or any discussion like that. But hopefully in the future that'll be more standard, so we have more of a regulated way to approach this problem. Because I know a lot of centers and a lot of medical folks and patients all deal with this so differently, so it's hard to get a good baseline system set up. Have I ever had the opportunity to sit with my providers to set personal goals for your pain management strategy? Yes, I have. Usually during each annual visit, when I do sit down with my provider, I do have a time set aside with them just to specifically discuss pain problems and issues like that. Again, me personally, I haven't had too many issues or things to worry about, so I've been lucky in that, that I haven't had to really have a really detailed discussion about specifics on how to go through things. But I have had those opportunities, and I know if I did have any long issues or difficult issues to deal with, that my provider would be very receptive to having that conversation. Also, social workers and PTs are very involved in that discussion. At the annual visit, I meet with those groups differently, but the social worker does check in and see how I'm doing with things. The PT is very detailed and specific about where I'm feeling pain, what kind of pain is it, how am I handling it, and issues like that. So with all of those three professions working together, I feel very comfortable with how my pain would be dealt with if I had some severe stuff. Have I tried to go to a pain specialist and been denied due to insurance or any other barrier? Luckily, I've not had to go to a pain specialist. If I did need any pain medications or any things like that, I would just talk to my provider, and the medications they would be able to provide have been helpful and allowed me to deal with that pain. So me personally, I have not dealt with a pain specialist. But again, I would feel very comfortable getting recommended outside of the HCC or my other physicians that I see to see a pain specialist if needed. So I hope that helps, and have a great day.
Well, thank you, Sean. And now I'm going to turn this over to Dr. Tyler Buckner to explain more in depth the Mesac recommendations on the management of pain, chronic pain, in persons with bleeding disorders. Dr. Buckner?
Thanks very much, Michelle. I appreciate it. I appreciate the introduction. So my job today is to talk about the Mesac pain guidelines. I'm from the University of Colorado and the chair of our Mesac Pain Initiative Task Force. And that group of individuals, as mentioned by Michelle, includes people with bleeding disorders, as well as nurses, physical therapists, pain specialists, medical providers, social workers, psychologists, researchers. And so this is really an expert group that's been working together for several years to move us forward as a community so that we're addressing the needs related to pain. And we will jump right in with some audience poll questions. So there'll be 3 of those, and I will read them. So the first question, this is number 4 overall. Have you ever been asked to sign a pain management agreement? Yes, no, or I don't know what a pain management agreement is. So about 20 seconds left. Again, this is, have you ever been asked to sign a pain management agreement? We'll talk more about what that is a little later. Thanks for taking the time to answer this question. And the next question will pop up. All right, the second one. Has your dose of opioids been decreased solely due to the opioid abuse and misuse crisis? Yes, no, or I don't use opioids for pain management. About 20 seconds left. Again, has your dose of opioids been decreased solely due to the opioid abuse and misuse crisis? And our third question, have you had any difficulty accessing your usual pain medications during the COVID-19 pandemic? Yes, no, or I don't use opioids for pain. And 20 seconds. Again, have you had any difficulty accessing your usual pain medications during the COVID-19 pandemic? All right, thank you very much for participating in our poll. So again, my job today is to introduce you to a document written by our Pain Initiative Task Force that was recently reviewed and approved by Mesac and then endorsed by the NHF board. This is document 260, Management of Chronic Pain in Persons with Bleeding Disorders, Guidance for Practical Application of the Centers for Disease Control's Opioid Prescribing Guidelines. And so that's quite a mouthful, but I did circle here the opioid prescribing guidelines. You'll notice as we go through that this document really focuses primarily on the use of opioid medications to treat chronic pain. There will be additional guidance documents from our group that are being drafted now that will cover other aspects of pain management. There are many important ways to approach pain. Opioids are not the only solution, and they're very rarely used in isolation. But this is where we started, primarily because this is a very important issue that affects a large number of people in our community, and because we had a place to start with the CDC's guidelines that were issued several years ago and are being updated, but we wanted to try to translate those so that they'd be useful for the hemophilia and bleeding disorders community. We won't go into full detail about this document during this talk. There's a lot more information than we have time for today. So feel free to read the document yourself. You can find it at the address shown at the bottom of the screen. You can also refer your hemophilia providers to this document. It's very easy to find simply by searching online for Mesac pain guidance, and it should be one of the first things that pops up. So it's easy to find and available if you're interested in going into greater detail. And let's go to the next slide. So in our guidance document, there are 4 sections or domains. And our goal here is to discuss how these recommendations that are in each of these sections might affect you as a patient. We'll try to discuss this from your angle and talk about how these recommendations, when put into practice, might affect you as a person who's experiencing pain. So we'll go through each of these now. Let's go to the next slide. So the first section is screening and risk assessment. And our recommendations are listed here on the right side of the slide. First, that all patients should be screened for acute and chronic pain. This is something that is not often completed at our hemophilia treatment centers around the country. That is something that we've shown in our group through the surveys that Michelle mentioned earlier. And really, because pain is such a common aspect of living with a bleeding disorder, we feel strongly that everyone should be asked about it and not just using the standard "how is your pain today" question. We think greater depth is useful, and we won't know about problems unless we ask about them. And so the second recommendation is related to the first. Our group feels that evaluations of pain shouldn't just focus on the intensity of pain and what is your 0 to 10 pain score, but really trying to get down to how does it interfere with your day-to-day life and how does it affect your ability to function within your daily activities, because those are important for us to know where things stand and later on if we're able to make a difference with our treatments. Third, we also recommend to evaluate anxiety and depression using what we call patient-reported outcome measures or tools, otherwise known as questionnaires. Dr. Wheat will address these issues specifically in just a minute. And then finally, we also recommend assessing for potential risks or any signs of problems associated with opioid use. We, I think, can all appreciate that opioids come with certain side effects and need to be monitored very carefully. And even before, but also during treatment with opioids, monitoring for these kinds of associated problems is very important, because we want to make sure that we're doing what's safe and what's best for you as a patient. And so that involves things like using the prescription drug monitoring programs that are available in the United States on a state-by-state basis, as well as other tools to make sure that there aren't signs that we may have problems. So those things are really done and recommended to be done, not to single any particular person out, but really to make sure that we're not missing something that would otherwise impact your safety. Let's go to the next slide. So the second section is deciding when to start or when to continue opioids. And again, we want to make sure that it's said out loud that our overall goal is to treat pain and to address pain, and at the same time ensure that the treatments that we use are being used as safely as possible. What I tell my patients and what we recommend to everyone is that if at any point it becomes clear that opioids are not safe for a particular person, they should be decreased over time and then stopped. If that happens, that doesn't mean that we no longer treat your pain or that we then pass you off to someone else to manage you. We should continue to treat your pain, but use different approaches, and just know that opioids are not an option. If they're not safe, they're not safe. The risks of opioids that we recommend making clear to anyone who is going to be treated with these medications include those that are listed on the slide, such as developing tolerance to the medications or dependence and addiction. Opioid misuse is a risk. Acutely, opioid overdoses can result in respiratory depression, which means you stop breathing. And if you're not breathing, you can die. And this is what we worry about and what has caused such strong reaction across the country to this opioid crisis, because these medications can be life-threatening if used improperly. Other side effects which are more common include constipation, feeling sleepy or tired, having confusion, sexual dysfunction, itching, and opioid-induced hyperalgesia, which deserves more discussion than we have time to go into today. Let's go to the next slide. So staying in the same section, in terms of how you choose between using an opioid-based treatment approach or non-opioid-based treatment approach, we always prefer to not use opioids if possible. So non-medication-based treatment is always important. And then non-opioid medications are also preferred over opioids. And so that includes acetaminophen, it includes other pain relievers and adjunctive medications that are not opioids. If you do have to use opioids, they should be used in combination with other treatments and not in isolation, always having input from multiple disciplines. And it's also important to remember for any pain management program, whether it has includes opioids or not, establishing goals for pain relief as well as function are important. And so focusing not just on, again, that number, that pain number or pain intensity rating, but also how well you're able to function. And then you have to evaluate those things regularly over time so that you know whether or not you're helping. Let's go to the next slide. So the third section is opioid selection, dose, duration, and other considerations. And so these are more specific recommendations on which opioids are recommended. First big discussion is whether to use an immediate release or a long-acting opioid. Based on a lot of evidence in the literature, we agree that the CDC's recommendation to favor using the immediate release opioids is safest and preferred. As with any medication, opioids should be started and used at the lowest dose that works, and not given or prescribed in greater quantity than what is needed. We recommend avoiding the use of opioids in another class of medications called benzodiazepines. Together, both of those medications, when used together, greatly increase the risk of respiratory depression that we mentioned before, and so are not a safe combination. We also recognize and point out specifically that it may not be possible to reduce opioid doses in all of our patients, especially in those who have needed opioids at higher doses or for a longer period of time. Typically that is in our clinics, that's due to having extensive joint problems, arthritis due to hemophilia or bleeding disorders. And so it's not always possible, but we do still have to monitor for side effects and assess the response and the impact of using those medicines over time so that we're doing our best to be responsible and safe with using the medications. Next slide. And the final section of the document deals with how we monitor opioids, as well as plans for reducing the doses or stopping when that becomes necessary. We recommend that the benefits and harms should be evaluated at least every 3 months, and especially in the beginning, even more often than that. So a connection with your HTC is very important so that you can report any problems, ask questions, and then let us know if it's working. That's very important information so that we know what's best moving forward. We do recommend using urine drug screens as well as reviewing those prescription drug monitoring programs at each visit. Really that's to screen and make sure that we're not missing any dangerous combinations of medications or illicit substances that would put a person at higher risk for overdose. So that those are recommended with an eye towards safety. And again, not to single any particular person out. We feel that these should be done across the board, really to ensure safety. For anyone who develops a condition called opioid use disorder, and there are many characteristics of this disorder, some related to dependence or abuse of the medications. We follow along with other groups' guidelines that recommend using evidence-based treatments for that, such as medication-assisted treatments with the drugs listed there, as well as behavioral therapies. And so that's very important for a very small number of people who need that resource. And then one final slide, just to wrap up. We include in our guidance document a few examples of tools that we think can be helpful. We mentioned earlier medication agreements, and rather than having someone sign a document that looks like a contract, we favor using these kinds of tools that can help set goals using your own words, that can help us track those over time, so we know if what we're doing is helping and making a difference, as well as to make sure that we do all the screening and our due diligence, really to keep you safe while we're using this class of medications to help treat your pain. And with that, I will wrap up and introduce our next speaker. So Dr. Emily Wheat works with me at the University of Colorado in our Hemophilia and Thrombosis Center. She's a clinical psychologist and provides care to patients with bleeding disorders. So I will turn it over to you, Dr. Wheat.
Good evening, and thank you so much for having me. Dr. Buckner, thank you so much for that elegant introduction. As our speakers before have mentioned, I'll have a couple of poll questions to get started with. So we'll move to those on the next slide. So our first question is, has your pain level changed during the pandemic? You might say it's increased, that it's decreased, or that you've experienced no change. And it looks like you have about 20 seconds, maybe a little less, to get those answers in. Okay, great. So we'll move on to our next poll question. Do you use other ways to control pain other than medications, such as physical therapy, mindfulness, meditation, massage, distraction, or something else? So you might say yes, no, I'm not familiar with how these options work, or I don't have a plan. You have a little under 15 seconds to put in those answers. Okay, great. Thanks so much for your participation. We'll move on. So I'm here, as Drs. Buckner and Whitcop mentioned, to talk about the psychosocial aspects of pain. And so in general, there's a mind-body connection. Our physical health and functioning impact how we think, how we feel, and what we do. And similarly, the actions that we take, our thoughts and attitudes, and our feelings can impact our health. And so for an example, in the world of hemophilia, it's been shown that acceptance of one's pain and negative thoughts, both thoughts and cognitive factors, can impact one's health-related quality of life. Stressors also influence our thoughts, our mood, and our responses, as well as our sense of well-being and health. And when you apply that to pain, research shows that those with chronic pain report increased psychological distress, greater life stress, and more non-pain somatic symptoms when compared to those without chronic pain. And further, evidence suggests that rates of depression and anxiety are higher in chronic pain populations compared to the general public. And because of this, as Dr. Buckner mentioned, and as I'll talk about in the next slide, screening for comorbid anxiety and depression for patients who are also seeking treatment for pain is really important. Next slide. So a couple of great free brief questionnaires that can be used to regularly assess patient symptoms of anxiety and depression are the Physician's Health Questionnaire, the 9-item scale, also known as the PHQ-9, and also the General Anxiety Disorder 7-item scale, or the GAD-7. There are also a few shorter versions, so the PHQ-4 could be utilized to screen for both anxiety and depressive symptoms within this population. And in general, screening for anxiety and depression within bleeding disorders populations is important even for those without pain, as psychological distress in individuals has been connected with worse medical outcomes. At this time, the CDC estimates that approximately 10% of males with a diagnosis of hemophilia self-report as having comorbid diagnoses of anxiety and or depression. And a recent meta-analysis examining the prevalence of mental health disorders in youth and adults with a hemophilia diagnosis has reported higher rates of anxiety, depression, and attention-related concerns than those mentioned by the CDC, with base rates of about 16% across those diagnosis groups. And in the next slide, I'll talk a little bit about some of the non-pharmacological or non-medication treatments for pain. And I first want to define what this is. So according to the Pain Task Force Consortium for Integrative Medicine and Health, these therapies include things such as therapies from licensed individuals, including acupuncturist, massage therapist, chiropractors, physical therapists, psychologists, social workers, and other mental health professionals. This can also include directed or self-engaged movement and meditative movement therapies. And this can include lifestyle and behavior approaches, and more specifically, behavior medicine approaches. So things like stress management, cognitive behavior therapy, meditation and mindfulness, lifestyle approaches such as diet and sleep hygiene changes, and each of these I'll talk about a little bit in more detail. But first, in the next slide, I'll tell you about the benefits for these non-medication treatments of pain. So one great benefit is that when using these types of therapies, there's a reduced risk of adverse events and addiction liability. Another benefit that tends to get people's attention is the low cost. While these treatments may at times not be covered by insurance and may accrue additional cost, a cost analysis from an interdisciplinary pediatric pain clinic found that interdisciplinary treatment of pain, and that included in this study acupuncture, biofeedback, psychotherapy, and massage therapy, along with medication management, reduced inpatient and emergency department visits, resulting in a hospital cost savings of over $35,000 a year and additional insurance cost savings of over $11,000 a year. So significant savings there. These treatments also have a long history in Eastern medicine, and in addition, you can use them independently, or if you'd like, you can use them along with a medication management routine for pain. And then finally, utilizing these types of non-pharmacological therapies may help to not only address pain, but also the associated concerns of stress reduction, anxiety, depression. Next slide. So here's a list of some general non-pharmacological treatments for pain. And so each of these modalities have evidence for the reduction of pain either in the hemophilia or bleeding disorder population or in populations with similar musculoskeletal and joint pain involvement. And so the first group is relaxation and mindfulness-based interventions, and this might include things like guided imagery, diaphragmatic breathing, also known as belly breathing or deep breathing, progressive muscle relaxation, so systematically tensing and relaxing muscle groups, and biofeedback, so paying attention to physiological processes like your heart rate or your skin conductance and using computer feedback to modify how those are working. Psychotherapy is another option. So while there are many psychotherapy approaches, they tend to fall under either the cognitive behavioral therapy or acceptance and commitment therapy orientations. There's also healthy lifestyle choices and the benefit of building self-efficacy. So self-efficacy means the belief in your ability to deal with or manage various situations. And when we build our self-efficacy, that also helps to improve our physiological health. Likewise, healthy lifestyle choices, such as changes in diet, exercise, sleep, reducing stress, etc., can also have a positive impact on one's health in addition to self-efficacy. So working on these types of interventions is likely to decrease one's pain. And then last are movement-related therapy, so things like yoga and Tai Chi. And these have a lot of evidence behind them for helping to reduce pain. In general, if you're ever looking for more information about these things, then the mental health provider, likely a social worker at the Hemophilia Thrombosis Center, is going to be a great resource for connecting you to someone who is a professional and can provide some support. That's it for me, and we can move to the next slide. I'd love to just say thank you to Dr. Buckner, Dr. Whitcop, and Mr. Jeffrey for joining me today. We'd like to ask that you take a few minutes to fill out the session evaluation. Your feedback is really important to us. And for those who complete the evaluation, you'll be entered into a raffle for the chance to win a $75 gift card. The chat will remain open, so feel free to ask your questions via this platform. And thank you again for joining us.